Welcome to today's webinar, Making Choices in Integrative Medicine. My name is Tamara Moore with the Reese Group, a communications firm in DC. I will serve as today's moderator. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of an attendee interface. You should see something like this on your own computer screen in the upper right corner. If you have joined the webinar by telephone, please ensure that your PIN number is entered, which can be found in the audio pane of your control panel. All attendees will be placed in listen-only mode. You will have an opportunity to ask questions during our discussion today. To ask a question, submit your question through the Q&A section of your attendee control panel. We will collect all questions and address them during the Q&A session at the end of today's presentation. If you have an issue with the webinar technology, you may type your question through the Q&A section of your attendee control panel, and someone will respond to you as soon as possible. You may also contact GoToWebinar technical support by dialing 888-259-8414. Today's presentation is being recorded and will be posted on the Leadership Program website in the coming days. I'd now like to turn the call over to today's host, Adam Perlman, Program Director for the Leadership Program in Integrative Healthcare at Duke University. Adam?
Thanks, Tamara. And thank you all for joining us today. We actually have a great program for you. But before we get started, I just want to mention that the Leadership Program in Integrative Healthcare is now accepting applications for our 5th cohort to begin in February of 2019. We accept applications until September 30th, but if you submit your application before June 1st, still a couple of weeks, the $100 application fee will be waived. And if you're interested in applying, you can get more information about the program and access sort of the very brief application at our website, which is, and we'll give you integrative.org. Or you can always contact Damien, who's our program director, and that's at Damien, D-A-M-I-A-N, Gallina, G-A-L-L-I-N-A, at duke.edu. I just want to say about the program that really what we do is through extensive, personalized leadership training, guided curriculum that was developed by integrative healthcare experts, and mentorship from faculty from Duke's Fuqua School of Business on sort of a final project and project planning. Our program really can and is changing healthcare leaders' lives, as well as the outcomes they achieve, and doing this in line with the principles of integrative health. And that's what's been so exciting about the program. So with this in mind, I think we're one slide behind. There's some of the contact info, so we can move forward. Thank you very much. So we can put information back up there. Sorry about that. But with this in mind, so there's some of the contact info I was talking about. You can see Damien's email there, as well as the email for the program specifically. And the misspelling. Great. And next slide, please. Thank you. All right. Without further ado, okay, I'm thrilled to be joined today by one of our alumni of the Leadership Program who's done really amazing things to further integrative healthcare. So Dr. Santosh Rao, a participant from our 3rd cohort, is really guiding the advancement of integrative healthcare as Medical Director of Integrative Medicine at the Banner MD Anderson Cancer Center in Gilbert, Arizona. He's a practicing medical oncologist. He focuses on genitourinary cancers and also participates in integrative medicine research. His research includes such things as sleep, meditation in cancer, the impact of integrative medicine on healthcare costs and outcomes, and art therapy and the effects on chemo brain. Today, Santosh will reflect on his personal experiences navigating between clinical and integrative oncology and how to best serve patients while being true to the culture of our practice environments. So with that, I'd like to turn the call over and the webinar over to Santosh.
Thanks, Adam. I wanted to thank the Duke Integrative Medicine Program, yourself, Damien, and Tamara for having me and allowing me to talk. Just a few words about the Duke Leadership Program. We just had our graduation in February. It was a fantastic experience. And I think, just meeting all of you, the networking, the partnership with the business faculty was really priceless, and I think it's made a big difference in my journey. So thank you for that. So as Adam mentioned, I'm an integrative oncologist. I practice at Banner MD Anderson Cancer Center, and Banner Health is a top 5 largest healthcare organizations in the country, and they partnered with MD Anderson Cancer Center from Houston to build our cancer center, and that's where I practice medical oncology, and I'm the director of our integrative oncology and cancer prevention program. I have been there for a little over 5 years, and my journey in integrative medicine really started back in college. That's when I decided to become a doctor, and what really turned me on to becoming a doctor was my interest in Ayurveda, Chinese medicine, yoga, meditation. So I was really passionate about all of this, but I didn't really understand how that would be put into practice. I certainly think things have changed a lot. That was a little over 20 years ago. And I remember going through medical school, I really tried to pursue my interest in integrative medicine, and there were a lot of challenges back then, just with how open my colleagues were. Sometimes they were very not open, and even would get mad if we talked about things like energy or even Tai Chi. And there have been times where those kind of things would dissuade me or discourage me. And so I found that fitting in and how how our integrative medicine fits into a changing dynamic in medicine is very interesting and takes some thought. And as the field has developed, I think that there are a lot of observations I've made about how sometimes this is a little messy and that there's no perfect way to do it. And so I wanted to capture some of those thoughts in this talk today. It's loosely based on an article I wrote for the Duke Leadership newsletter from winter that was titled Integrative Oncology, Making Choices to Fit In While Changing the Culture. And basically, it gets back to how we practice integrative medicine and how those decisions get made, the fact that there's sometimes little agreement in terms of what we are actually saying, there's few guidelines, and how do we make it work while working with others. I was lucky enough during some of my training periods to shadow a lot of people, and my observations are that while many of us would agree on paper with things that we consider beneficial, in practice we're quite variable in terms of what we do. So my talk is going to be focusing on what integrative medicine really is, who do we call an integrative provider, and how do we practice it in different settings. Next slide, please. So I want to talk about a couple definitions of integrative medicine. The first one is from the Academic Consortium, and it says integrative medicine is the practice of medicine that reaffirms the importance of the relationship between practitioner and patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic approaches, healthcare professionals, and disciplines to achieve optimal health and healing. And the axiom is integrative medicine treats the whole person, not just the disease. So I want to take a step back and look at that and say, how does this distinguish us as integrative providers, as integrative researchers, as those interested in integrative medicine? And I think if you're not part of that group, which most of us would say we are part of that group, and you look at that again, I think there are elements of that that are not unique. You know, the importance between the practitioner and the patient. I think most practitioners would say that they have placed a lot of importance on their relationship with their patient. Focus is on the whole person. I think that's not entirely unique to us. We say it is, but I don't think that's necessarily true. All appropriate therapeutic approaches is kind of a loaded statement. I think probably the most unique statement in there is that we look at optimal health and healing. And I think one correct criticism of conventional medicine is that they don't really have a good definition of what that means. But I think that that's important to look at that and be honest. And I'll continue to talk about this during the talk, but it's interesting when you look at who's doing research in integrative medicine, it's not necessarily just people who are quote unquote focused on integrative medicine. Many of these folks are just stumbling upon elements of integrative medicine and are otherwise, well-known researchers in their own respective fields. And the same things go sometimes clinically, where somebody who's already established has some interest in some element of integrative, and then they get absorbed into our field in some way. Next slide, please. So I'm part of the Society of Integrative Oncology, and we recently put out a more specific definition of what is integrative oncology, which I think is a little bit better. If you look at it, integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and/or lifestyle modifications. So it's getting into more specifics of how we're unique from different traditions alongside conventional cancer treatment. A lot of elements in that I think are a little bit more specific in terms of being patient-centered, evidence-informed. These are kind of important statements, some of the modalities we use, and using the term different traditions. Integrative oncology aims to optimize health, so the same type of statement there, quality of life and clinical outcomes across the cancer care continuum. And I think one of the most important parts of the definition is to empower people to become active participants before, during, and beyond cancer treatment. I think that last part is very important. Next slide. I think part of this is, who are we when we say that we're integrative providers? What makes one an integrative provider in the first place? I think it's an important question. Most of us who have jobs in integrative medicine have put ourselves out there as saying, hey, I'm an integrative provider, or I've done some training. But what kind of training makes one an integrative provider? There's no agreement on that. There's lots of different avenues, and while that's good, that also makes the field very, very diverse, but difficult to define. Is it an integrative medicine fellowship? Is it an acupuncture training program? Is it somebody who comes from another country who used to practice traditional Chinese medicine earlier in their practice? It's all of the above, but it also makes it difficult to explain that to somebody. And my experience is that most administrators who are hiring, they don't know the difference. So, until we get scrutinized more, this hasn't become an issue. There's some movement towards more definition of what makes an integrative provider, that you might have to take a board exam, for example, if you're a physician. But generally speaking, we're kind of flying under the radar right now, and it's enough for us to say, hey, I'm into integrative medicine, and you tend to get absorbed into it. But it's difficult to define, if somebody's really scrutinizing that, what is it that made you an integrative provider? Is it the personal journey or our way of interacting with patients? So this is a common thing we talk about too, that we have this, patient-centered, personal approach to dealing with patients. I push back on that. I think that there's some truth to that, but at the same time, there's so many wonderful caregivers who have never heard of integrative medicine or done any training. So I think that, our background is important. Most of us have some unique kind of experience that makes us go into this field, and we bring that with us. But again, it's very diverse. Is it the knowledge of the literature and practice? I think to some extent, yes. I just took a board exam 2 days ago, and I can tell you it was really hard to study for, because there's no perfect study material, perfectly accepted textbook. There are textbooks out there, but there's stuff that's in there, and there's stuff that I would argue is not in there. The guidelines are not always practical in terms of what's put out there in the literature for how we might practice. But I think that if there's any definition, knowledge of the literature is a big part of what makes us unique. Is it the focus or inclusion of complementary therapies in our practice? To some extent, but anybody can actually include complementary therapy. So unless you're the practitioner yourself, if you're a radiation oncologist and you say, I want to start an integrative program, nothing is stopping you. And does that then make you an integrative provider? And then, is this a specialty, is it a philosophy, or is it a movement? And I would argue that it's all three. I think that in some ways it's a specialty in terms of having a specialized knowledge, reading and focusing on that area of the scientific literature, going to conferences, etc. But it's also a philosophy that we have a common approach that is kind of guided by some of those definitions that we talked about, and it's a movement. I think that there's a lot of different philosophies and different types and styles of treatment that are kind of being brought together, and there are people joining this movement. So I would argue that it's all three. And part of it being a movement is that we want to be welcoming to those who are starting to find this, and it's becoming more popular. But what I want to talk about a little bit is as people come on board and interact with integrative medicine, as it stops being off to the side and starts being more part of the fabric of healthcare, you find that what different people think about what it is, it may not be the same as what you might think. So they may want to limit it to a particular part of integrative medicine that makes sense to them, a particular style, rather than everything. And so that's interesting to me, is we may not all be unified in terms of what we think this is. Next slide, please. So going back to the initial definition, what separates us, I think that the most important areas that really separate us to call ourselves integrative practitioners is that we focus on different traditions alongside conventional treatment, and that we want to empower people to become active participants. That doesn't mean that other people can't do those things, but to me those are probably the most unique aspects. And I wanted to go into all that because it's important when we think about how we position ourselves in a practice. What is it that we offer, and what is it that might make us unique, where we can kind of go back at somebody and say, hey, listen, we're the experts, and we have a totally different approach that needs to complement the conventional care. Next slide. So I'll talk a little bit about our program. I don't want to read this whole mission statement. It's very similar to what we've already talked about. Basically, the name of our integrative program is called the James M. Cox Foundation Center for Cancer Prevention and Integrative Oncology. This is the mission statement. So we got a grant from the family of Cox Communications, and that basically supports our program. And next slide. Our program is generally based on the same model that they use at MD Anderson Cancer Center. So this is a model of integrative medicine where it's thought that optimal healing is kind of a collaboration of approaches with psychospiritual, physical, and social well-being. And I think that most of us would probably agree that this is a pretty good model. I will say that our personal practice style is very different, though, than what they use at MD Anderson, even though we've kind of co-opted this model. And what I find very interesting is how you can list all these things, but that doesn't necessarily capture what it is you're actually doing. And like I said before, from my experience from shadowing different people, it's actually quite different what people are doing. So the other thing I wanted to mention is where does conventional care end and integrative medicine begin? And you can look at all these different areas. So integrative oncology consultations, nobody does the same thing. So just listing it as this is an integrative oncology consultation, it's in MD Anderson, for example, in Houston, they're quite conservative in terms of what they recommend. Everything has to have a very, very high level of evidence. In other centers, that's not always the case, right or wrong. You look at some of these other areas that we would consider integrative, like rest and sleep, environmental exposure, support groups, education. you look on the left, and there are some areas like nutrition, for example, quite diverse. What do each of these people say? How is exercise recommended? Who's recommending it? Smoking cessation, it's done a little bit differently in different programs. Our program is different, for example. I'll touch on that in a second. Next slide. So these are the services that we offer. You can read through the list. I think some of the highlights I would make is that we have a study on a tobacco recovery program, and we decided to make it a holistic program. We incorporate hypnosis, acupuncture, essential oils. It's unique, but that's not something that would be done everywhere, you know. And so some of that is the fact that we're studying it, but a decision had to be made as to whether we're going to have a 100% evidence-based approach or whether we're going to do something that is more holistic and quote-unquote integrative. We incorporate integrative medicine in our cancer survivorship program. We try to be diverse in terms of our consultations. We have 2 providers who have some training in functional medicine. I myself have training in Ayurveda. We have an integrative health psychologist who does a lot of great work. Our dietitian's able to do functional testing, elimination diets. We offer acupuncture and infusion, which is unique. And, you know, we do some community outreach, and et cetera. So next slide. So the next question is, after you decide what is it that makes us unique, is who is going to be part of the team. Integrative care is collaborative by nature. You have to think about what you can do, you know, who's available. I remember once somebody asked me about starting a program in Saudi Arabia, for example. And when we got to talking about what the actual makeup of their program would be, you know, my first thought was acupuncture, and they said, well, we can't get acupuncturists there. So you have to think about who can actually get hired in that area. What is the appetite for risk? You know, some areas, for example, nutrition is very well accepted, you know, but there are other areas that maybe there's less evidence for, like Reiki. So what is the appetite for risk? You know, how far outside of the mainstream are you considering going? What's the business model? You know, is it a grant-funded program where you can offer things for free and money is not as big a deal, or do you have to get reimbursed just to support your program through billing, et cetera? And then what's the culture like? What do you think will be well accepted? I think that answer is very different in different areas. So, you know, within the institution or the center, the community, as well as between peers and referring providers, something that I think changes over time as people get more accepting. But there are some areas of the country, for example, California tends to be more liberal, whereas the Midwest tends not to be. Next slide. So I'm just going to go through quickly some of the choices we made and then some of the interesting questions that come up when you include these things. So I think the no-brainers are dietitian. Next slide. But within that, you know, there are choices to be made there. Do you start doing functional testing? You know, there are stool tests, there's different nutritional tests, there's genetic tests that are out there. Do you consider the ketogenic diet something that would be worth talking about or not? All these are controversies right now. Next slide. With yoga, you know, yoga has a lot of evidence, but in different locations with different populations, we have a pretty conservative patient population. They're not always accepting. What kind of experience do you have to teach yoga? Is it oncology specific? These are all things that are important. Next slide. With acupuncture, what is the cost model? Is it insurance reimbursed or not? Safety guidelines is something that MD Anderson has that we've incorporated, but I don't think is universally applied. And then I think a really important question is whether you incorporate traditional Chinese medicine. For example, at UCSF, they do, but that is not easy to incorporate in a traditional setting. So in our center, for example, we don't. And these are all just questions. There's no right or wrong. Next slide. For physical therapy and exercise guidance, who guides the instruction? We used to have an exercise physiologist. We moved on to having physical therapists. There were reasons for that, but what kind of specialization do you really need? Next slide. There are issues with group sessions. We've had questions about billing, about liability, if it's a social worker versus a psychologist who's running it. We have issues with no-shows, for example. That all goes into the calculus of how you offer these sessions. And then lastly, a chaplain. I think a chaplain is available in pretty much every cancer center. Our chaplain is part of our integrative program, we feel. But if you're not of that denomination or faith, they'll still serve you, but will you feel comfortable as a patient asking a chaplain to come for the same kind of purpose if you're not of that same faith? So these are all issues that come up. Next slide. And then there are other things that can be incorporated, but aren't always. So, integrative consults, obviously they're done in different ways, using different cultural medicine approaches like Ayurveda, TCM, Native American medicine, shamanism, homeopathy. There's a lot of bias. There's a lot of different viewpoints on whether those things fit in or not. And so you kind of have to make a decision. I think energy healing, for example, is very interesting to me. It's offered at a lot of places, for example, Reiki. But from my experience talking to different people in the field, their view of energy healing is all over the place. And so if you can't even agree what's going on, the mechanism, is it validated or not, it's difficult to explain to somebody outside our field why we're doing it. Body work. I can skip some of that. I think health coaching is interesting also. I'm a fan of health coaching. I don't think it's yet been utilized highly, but I think that there's a lot of room for growth in health coaching. Next slide. So I want to go through a couple of situations that we had and just talk about it. The first one is there's a postmenopausal woman with a history of estrogen-positive breast cancer who sees an integrative practitioner for arthralgias. They are recommended acupuncture, yoga, and other exercise, vitamin D at that dose, 5,000 units per day, omega-3, turmeric, SAM-E, arnica, and an essential oil topically by doTERRA called Deep Blue. So the question I have, and that's probably what I would do. There may be one or two other things that I might change, but pretty usual response on my part. And the question is this right? Is this the right thing to recommend? Obviously, I think so. But in each of those things, there's some disagreement. How often do you do acupuncture? I would argue acupuncture has some validity to it. Exercise does too. But most of the studies with exercise are not really comparing yoga versus other exercise. So when you tell somebody, well, you should do some yoga, you should do some exercise, it'll make the joint pain better, we don't have a great idea of the specifics. The dosing of vitamin D, what level are you targeting, dosing of turmeric, etc. How did we decide that this would be useful? So that gets into some of the ways each of us are different in terms of looking at the levels of evidence. When there are guidelines, and I will talk about guidelines in a minute, that come out, I don't always agree with the guidelines. And that doesn't make me right, it doesn't make me wrong, it's just that we view these things very differently. And how do we justify this plan to others? And that's also important. Just because you want to do something, if you're in private practice, it's really just you and the patient. But if you're in a consultative setting in a center, you end up having to justify this plan to others. And sometimes you can't. Sometimes that's not the same as what you would do. I find that interesting. Next slide. So that goes into kind of a decision analysis as to what to include and why. And I would argue that how we practice in academics is different than if you're an integrative provider in private practice, and it's also different than the way our patients think. We know that the sicker you are, if you have cancer, for example, the more tolerant you would be in terms of the risk that you take with taking different supplements. So, integrative oncology guidelines have been produced, they're starting to be produced, but they don't, in my mind, really guide our practice. They're mostly reflections of the level of evidence that exists. I think there are some great books, and there are more books coming out, but they're susceptible to bias. You know, there's some things that I think may be useful that are sometimes not included, and that they need frequent updates with research. And if you look at conventional cancer care guidelines, they're much more prescriptive and easy to follow. And so we have a harder time knowing where to draw the line. Next slide. So here's an example of the NCCN guidelines in prostate cancer, and this is an area of controversy of how we treat M0 castrate-resistant prostate cancer. It's a pretty active area in terms of research, and there's a pretty easy to follow algorithm. You have a choice depending on how fast the doubling time is, whether you consider apalutamide, whether you consider adding oral agents that are other hormonal agents, and then there's you know, a follow-up to that. Anybody can follow this, and what I find is that there's a lot less discrepancy between oncologists than there is between integrative providers, and it's partly because of this kind of phenomenon. Next slide. Another situation that came up is one of our integrative providers was seeing a patient and suggested some supplements, and some of our providers were uncomfortable with their patients using any supplements. And we had a meeting, and it was you know, face-to-face, and the oncologist said, I don't want any of my patients being on any supplements at all, not even if the patient's just on surveillance. And so we had to really talk about this, and we had to make some decisions as to what to do when these people's patients were consulted. Do we change our practice style at all? Do we modify our interactions based on the referring provider? And you know, I would argue there's not a right answer, but it's an important question, because if we continue to upset a referring provider as a consultative practice, they may not send us patients anymore. And we also don't want to get into this game where we're totally disconnected with what another care provider is saying to a patient. If there's an oncologist who immediately will discount what I said and tell their patient, hey, you can't do that, I don't think we're accomplishing a lot. We're probably confusing the patient. This brought up a lot of trust issues. You know, who can adequately make these decisions? You know, does it have to be a physician, for example? You know, on the oncologist side, they got their own pharmacists involved, even though we're often screening for drug interactions. There was a whole bunch of this kind of trust, and it can get really out of hand. And I think that what it underscores to me is that even if people are interested in using our services, they may not completely understand what those services are and what they entail, and they may not really believe in integrative medicine the way we see it. And so, you know, I think that brought up a lot of controversy, and we're still working our way through that. Next slide. So, you know, for me, it's about what is the right way to practice, you know, from our integrative viewpoint. I think we have to figure out how to serve our patients while being true to the culture of the practice or environment you serve in, cooperating with other providers. And you have to make decisions on how far you're going to go. And I do think you need to cooperate with providers. That's part of the integrative model. I think communication is key, but there's an aspect of this where you have to teach other providers who may not understand elements of lifestyle. Diet, for example, there's a lot of ignorance around. And so we have to educate ourselves, but we have to be able to teach and educate others. We need more evidence. You know, people tend to adopt things that have evidence, even if they don't agree. And I think that, you know, if there's not great evidence, we need more consensus opinions from experts, including international experts, on how to put this all together. Next slide. So my steps and recommendations, if you're kind of either developing a clinical program or have a clinical program and have any of the issues I talked about, which I think we all do, I think it's really important to get buy-in from peers. You know, that grows the program. Obviously, you get your patients, but they can strengthen the program as well by scrutinizing it and helping you understand how to make this make sense to providers who are maybe not integrative. I think starting small and building a good reputation is essential. There are a lot of programs who get who get a bad reputation and they end up suffering because of that. I think one of the most important things is for your team is to get people on your team who have a similar approach and mindset. You know, nothing can shortchange your team more than having one or two providers who just does their own thing and has a completely different style and thought process. Then it reflects on your whole team, and it can be difficult to kind of get it back and build that trust again. I think it's important to be open to feedback and criticism. Many times I don't get feedback, and we just kind of fly under the radar, and we're really just kind of getting feedback from our patients. I think it's important to get feedback from providers as well, so you engage them, but some of the feedback you get is important. You need that check and balance. I think we all need that. Develop ideas around a best practice or consensus opinion in the group. I think many integrative programs have a journal club. They review research together. They talk about how they practice together. The reason I mention that is I have seen it myself where I would argue most of the time in integrative programs, different practitioners actually have their own style. And some of that is okay. But you know, in the oncology world, for example, if I'm a breast oncologist, we certainly will argue, debate as to why we're doing different things. And we need to do the same thing on the integrative side. And lastly, participate in research and literature review. I think it's important that we try our best to be part of developing this field and engaging with others from other centers so that, you know, we aren't growing in a bubble, but we're really building this field together. Next slide. So as I reflect on integrative medicine, where it is and what it means, to me, integrative medicine in part is getting back to the origins of medicine, finding our way back to our roots. And, you know, this is a quote from Hippocrates, walking is man's best medicine. And in a way, I see medicine in general trying to get back to some of its basic roots. Next slide. Before I end, I'm just going to put in a plug for a conference that I'm chairing in October in Scottsdale. So it's the annual Society of Integrative Oncology Conference. It's going to be October 27th through 29th. We have a great program. Our keynote speakers are Andrew Weil, Patricia Gans, and Erin Ben Aryeh, who's from the Middle East. So hopefully some of you can make it. And I'll leave at that point, and you guys can ask questions.
Great, thank you. We do have a few questions in the queue. As a reminder, to ask a question, submit your text question through the Q&A section of your attendee control panel on your screen. Our first question refers back to a slide you just presented. What are some of the tactics you use to recruit and support buy-in from your leaders and peers?
Thank you. I think that first of all, going and talking with them. You know, so if we have an oncology group conference, or I went and talked to the surgeons, for example, they want to hear from you. They want a chance to engage. They want a chance to ask you questions. So I think that that's number one, is going and just talking to groups, presenting them with what you do and why. And then not hiding. I think that I'm willing to engage with people on what we're doing and why. I think the other thing that helps me personally is being an oncologist. I'm kind of seen as part of conventional care, and I think that that's served me well. You know, is just whatever your setting is, kind of still engaging on the conventional side and not trying too hard to be just complementary or whatever, just integrative. That we have common purpose, it has helped a lot as well.
Great. This question, next question is, how can others start conversations within their own practice setting to begin to develop support for integrative approaches? So going from more of a more conventional practice to an integrative one.
Yeah, so that answer is going to be different depending on what circumstance you're in. I think if it's a larger program, there usually has to be somebody who's a champion, somebody who's probably at least supportive. On the flip side, I think that most people are interested. It's just a question of money and having the time and energy to devote to developing a program. So there are a lot of people I've talked to who just have this idea that I'm going to start doing an integrative program. We had a colleague of ours who was just in our leadership course who did that, and she found support, and I think that because these are attractive to patients, most leaders in healthcare settings, they want this, but they may not necessarily know how to do it or have the time. And so if somebody takes the initiative, then it makes it easier for them. But then once you do take that initiative, then you need to have a champion, somebody who's probably above you, who is going to have your back. I think that's really, really important. And then you need to sell the message. Why is this important? And then be practical. So a lot of it comes down to funding. If you got a bunch of money, that just came from a grant, it makes it a lot easier. Usually in that situation, they have an agenda or they have something, a proposal and a mission. But if you don't have that, then you have to have kind of a business plan in addition to the vision and concept. And most of the business folks and the chief financial officer folks who you still need to get on board, that's what they're going to be focused on. What is your business plan? How is this actually going to work practically? How do you justify your existence? So you need to get those people involved as well. But usually it starts with having vision and getting a champion.
Great. Our next question, do you consider immunotherapy with infusions of natural substances integrative oncology?
Yes. I mean, so infusions of natural substances, what does that mean? When I think of immunotherapy, I'm thinking of certain drugs. So, Opdivo, et cetera. And we don't incorporate anything else in that. So, in a way, I think there's a line that has to be drawn between what we would consider integrative and alternative. So that's another thing that's a gray area. Where do you cross that line? There's things that we don't offer, for example, because it's not part of our pharmacy kind of drug dispensary, and they consider it alternative, whether that's IV vitamin C or insulin potentiated chemotherapy. You'd have to argue that some of these things, some would argue are integrative complementary, and some would argue that they're alternative.
Great. And so since this is sort of a new area, in hiring integrative practitioners, what are some of the things that you look for, whether it's experience or characteristics that they bring to the team?
Certainly experience is highly valued, and part of that is that the more experience somebody has, I think that they probably have been through different situations that make them savvy. So that's always a good thing. And then more than anything else, like I said on the slide, I want to make sure that they have a similar mindset, that they know how to function in the setting that I work in. Are you going to be telling people, and this happens all the time, are you going to be saying stuff that I probably wouldn't want you to say? And that's difficult, and sometimes you need to even talk to people after they get hired to continue to refine what messages we're sending. But as early as possible in the process, you want to get a sense of whether somebody can fit into the culture so that, as a team, you're building trust. So if they've got experience in the same kind of job, if they have experience doing this for some time, they're good at what they do, they have energy, and they have goals that are in alignment with our programmatic goals, they bring something to the table. Those are all the things that I look for.
Thank you. Our next question is for Adam. One participant asked, what is the difference between the in-person experiences and the online curriculum?
Sure. Happy to answer that. So, and again, with a lot more detail on our website, you can see the 40-plus modules that, again, were developed by faculty from really across the world, most North America, and in various topics related to everything from finance to leadership skills and communication to integrative models of care. So that piece you do over a 6-month stint, but the experiential piece is really working with, for one, an excellent executive sort of leadership coach, a guy named Mike Aquilino. I've worked with him for many years. He's worked with Mark Hyman, so he's not only, and he typically works with Fortune 500 companies and CEOs and executives, so he's not only a very seasoned executive coach and leadership coach, but also knows the integrative space, and of course has been involved with this program really since its inception. So you get a lot of work with him. We bring in speakers. You're doing a lot of networking and connecting with the other faculty who in themselves are tremendous leaders within integrative health, Ben Kliegler, Lori Knudsen, and Bonnie Horrigan. And you do that over a 3-day period. Then go and do the curriculum for 6 months, and then maybe I'll just continue. You come back to Duke, you spend another 3 days doing similar things, not only working with Mike, but we bring in speakers from across the country too, who might bring an interesting perspective. And at that second immersion, you actually get paired up with your mentor from Fuqua, which again is Duke's Business School. And so you've already submitted a proposal, and you work with the same mentors that the business students work with, and kind of working and refining that proposal that you can then bring back to your institution, organization, whatever your space is, over the subsequent 6 months. Again, you get paired up and you work for 6 months with your mentor until you come back for graduation. So, and that pairing up also happens during that second immersion period.
And we have time for just one more question. Someone would like to know, where do you see your program going from here? Where are you looking to build, or your vision for it?
So a couple things. We want to do more work on the inpatient side. I think that's an area of growth. And then secondly, we want to expand. So Banner has it spans 5 states basically, and there's a lot of different clinics and hospitals. And so we want to expand some of our integrative care to get into some of those other spaces. I think that's an area of growth. And then lastly, we're not trying to grow our team, but we want to continue to diversify. And so I personally feel that if I'm a patient, I want to have access to people who can do different things. So for me, that might be Ayurveda, or for somebody else, it might be functional medicine. We want to be able to offer as many things as we can. We're trying to have programs the way they do at Duke, which are great. So those are some areas that we want to grow in.
Great. Adam, do you have any final closing remarks for us as we end today's webinar?
Sure. I mean, first of all, thank you, Santosh. I mean, it was a great presentation. There was a lot of really practical insights, and clearly, you're a great example of a transformational leader in integrative health. And so I really appreciate you taking the time to do this for us all today. And I want to thank everyone for joining, obviously, this webinar. Just reminding people that if they want more information about the leadership program and more details on the experience, then go to, as it says here, but www.integrativehealthleaders.org, and you can not only find out more information about the program, but you can also access a recording of today's webinar and check out some other really great resources we have available. We've written several white papers around sort of the philosophy of leadership within integrative health that also bring a lot of pragmatic tips in, and other information on our alumni. You can choose to sign up in our newsletter and see sort of recent articles that are written not only by our faculty but other leaders in the field of integrative health. So as a final reminder too, again, I would say if you're interested in being part of our 5th cohort, which is starting in February, your best to try to get your application in before June 1st, because then the $100 application fee will be waived. So again, I just thank everyone for joining us today.
Thank you, Adam.
Thank you. That concludes today's presentation.